In neonates with opioid withdrawal, does symptom-based dosing decrease time to hospital discharge? Does a whole health team approach reduce pain interference for veterans with chronic pain? Is recurrence of chronic subdural hematoma reduced following embolization of the middle meningeal artery? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners all around the world. Today is Friday, May 1st, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. Today I'm joined by JAMA Senior Editor Dr. Ann Cappola. Hi, Ann.
Hi, Linda. Let's start with a research article about neonatal opioid withdrawal. Neonatal opioid withdrawal is a serious concern with one U.S. infant diagnosed every 27 minutes. Historically, clinicians have relied on scheduled tapers, but that approach treats every baby as if their withdrawal will follow the most severe, prolonged course. Dr. Lori Devlin and colleagues enrolled 626 infants at or beyond 36 weeks gestation who were at risk for neonatal opioid withdrawal in a cluster crossover randomized clinical trial in 23 U.S. hospitals. Sites used the Eat, Sleep, Console or Finnegan-based care models. Sites were randomized to either symptom-based dosing followed by scheduled opioid taper or scheduled opioid taper followed by symptom-based dosing. The investigators report that the symptom-based dosing shortened the time to medical readiness for discharge, which was the primary outcome, by an average of just over 2 days. Adverse events were rare and similar in both the scheduled opioid taper and symptom-based dosing groups. There was no difference between groups in initiation of pharmacologic treatment or length of stay. Additionally, 35% of pharmacologically treated infants in the symptom-based dosing group required scheduled opioid dosing due to 3 as-needed opioid doses in the previous 24 hours. For infants with neonatal opioid withdrawal, symptom-based dosing was safe and got babies ready for discharge sooner. This could shift practice toward more individualized, as-needed opioid therapy and away from routine prolonged tapers for neonates.
The accompanying editorial by Dr. Grossman and colleagues takes a close look at symptom-based, as-needed opioid dosing for infants with withdrawal. They note that symptom-based dosing in conjunction with the Eat, Sleep, Console-based assessment should now be considered the evidence-based standard for pharmacologic management of neonatal opioid withdrawal syndrome.
Linda, let's turn to another important clinical topic, chronic pain. There's a pressing need for effective patient-centered long-term strategies. In a VA setting, Dr. Seal and colleagues assessed 3 different strategies to improve pain interference. Across 6 VA systems, the investigators randomized 764 veterans with chronic pain, mean age 60.5 years, mostly male, to one of 3 groups, a whole health team intervention, group cognitive behavioral therapy, or usual care. The interventions were delivered virtually and were provided over 12 months. The average pain interference score at baseline was 6.6 on the Brief Pain Inventory Interference Subscale score, which can range from 0 to 10 points with higher scores indicating worse interference from pain. All groups showed improvement, but the average pain interference score decreased the most in the whole health group, an additional minus 0.58 points compared with the cognitive behavioral therapy group and minus 0.77 points compared with the usual care group. Both of these comparisons were statistically significant. There was no statistically significant difference between cognitive behavioral therapy and usual care groups. These findings support the U.S. Department of Veterans Affairs whole health approach, though the differences are small in magnitude.
Dr. Shiva Shankar and colleagues assessed whether adjunctive embolization of the middle meningeal artery can reduce recurrence of chronic subdural hematoma compared to surgery alone. 186 adult participants with unilateral symptomatic chronic subdural hematomas who had surgical drainage were randomized to adjunctive embolization of the middle meningeal artery performed within 72 hours or to surgery alone in an open-label, blinded outcome trial at 9 Canadian centers. The primary outcome, symptomatic recurrence seen on CT scan at 90 days, occurred in fewer of the embolization after surgical drainage group, 4%, compared to the surgical drainage group alone, 28%. Recurrences seen only on imaging were also much lower with embolization of the middle meningeal artery. Serious adverse events and mortality were low and similar between groups, and no serious complications were linked to the embolization. The authors conclude that embolization of the middle meningeal artery after surgical drainage reduces the risk of symptomatic recurrence in chronic subdural hematoma. These findings support embolization as an effective new adjunct, potentially changing routine care for this common neurosurgical condition.
Linda, let's turn to the JAMA research letters and start with a study of potassium supplementation. Clinicians know that the right potassium levels are important, especially after cardiac surgery. But how aggressive should potassium supplementation be after coronary bypass surgery? In their research letter, Dr. Campbell and colleagues report 6-month outcomes of the TIGHT-K randomized trial from the UK and Germany, which compared relaxed potassium supplementation, only if potassium dropped below 3.6 milliequivalents per liter, to tight control, supplemented below 4.5 milliequivalents per liter, after coronary bypass surgery. 1,667 patients with average age 65 and of whom 15% were female were included. The researchers report that there was no difference in mortality at 6 months, at 1.2% in the relaxed group and 1.1% in the tight group. The investigators also report similar quality of life scores and incidence of atrial tachyarrhythmias, new strokes, and adverse events between groups.
Dr. Johannesson and colleagues report birth outcomes after uterus transplant in their research letter. Uterus transplant offers women with absolute uterine factor infertility, typically congenital absence of the uterus, a chance to carry a pregnancy. In a single-center cohort, the investigators reported live births after uterus transplant from 2016 to 2026. 31 live births occurred in 27 unique individuals. Premature rupture of membranes occurred in 16%, spontaneous preterm labor in 13%, and cervical insufficiency requiring cerclage in 10%. Median birth weight was 2,900 grams, and all neonates had 5-minute APGAR scores of 7 or higher. These data suggest that uterus transplant is feasible for well-selected patients at specialized centers.
JAMA listeners know that clinicians worry about AI's role in healthcare. In a thought-provoking viewpoint, Dr. Martinelli and colleagues say we are missing the real story. The solution isn't eliminating doctors, it's letting AI handle the paperwork so clinicians can reconnect with their true calling, being present for patients.
And continuing with that theme, in their perspective, Drs. Derby and Burston explore burnout in healthcare, arguing that only real systems-level accountability, not optional, quote, wellness programs, will improve clinician well-being. The lesson from the patient safety movement, embedding cultural change, disciplined measurement, and redesigning work itself are the true levers for lasting improvements in workforce health.
In another AI-related perspective, Dr. Bergman and colleagues address the coming wave of clinical artificial intelligence. The authors propose a national licensure model, similar to what's used for physician licensing, to avoid patchwork regulation and ensure that autonomous AI provides safe and effective patient care.
JAMA has a new review authored by Dr. Turnus and colleagues on cardiac resynchronization therapy. The authors used evidence-based information to summarize how heart failure related to electrical conduction problems can be improved with pacing strategies. In this week's JAMA Clinical Reviews podcast, we heard more about cardiac resynchronization therapy from JAMA Review corresponding author Dr. Mihail Kalu of Baylor College of Medicine. Here's Dr. Kalu.
By and large, what we mean by desynchronous beat is desynchrony at any level between the atria and ventricles, between the ventricles and within the left ventricle. Really, what we will discuss in this review focuses on desynchrony between the atria and the ventricles, as well within the left ventricle. And when you have disease in the conduction system of the heart that creates dysynchrony between the atria and ventricle, manifested most often by low ventricular rate, bradycardia with inadequate cardiac output. The other type of disease, it's disease that occurs either within the His or the left bundle, which manifests most as left bundle branch block and affects the dysynchrony of the left ventricle, manifested by heterogeneous timing of regional myocardial activation.
There's a new JAMA clinical challenge. See if you can make the diagnosis for a 35-year-old woman who has developed symmetric, sharply demarcated leg hyperpigmentation during pregnancy.
The JAMA patient page provides more on the diagnosis, treatment, and prevention of tetanus, a rare but dangerous disease caused by Clostridium tetani from soil entering wounds. And as always, there is a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes. That's a wrap for this week's JAMA Editor's Summary. Thanks, Anne, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Anne Cappola and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.